We don't normally go straight to feedback off the top of the news bulletin, but we have Pippa MacKay, Dr. Pippa MacKay, standing by to join us, and I think this is very relevant to what we're going to discuss. We've been looking obviously at the Southern DHB, and we broadened out today to look at DHBs across the board. I'm recovering from surgery for a torn meniscus, which is a knee tear, which I have had to pay for. The alternative was to wait about a year. Once referred, my doctor estimated. I'm a teacher and have been on crutches for several months, which has not been easy. I live in Southland, lucky me, so that person is part of the Southern DHB. My 75-year-old aunt, who's been in high chronic pain for years in one knee, is a non-smoker and in otherwise good health, has repeatedly been told by her GP that she needs to be crawling into surgery before she'll be regarded as worthy of being on the list. The criteria for the list is a bad joke, and I don't think she was alone in saying that today. The 75-year-old aunt that feedback describes. GPs across the country aren't referring people to public hospitals for investigations, advice, treatments and surgery because they know patients will never get on the waiting list. That's what New Zealand Medical Association President Pippa MacKay told a general practitioners conference in Christchurch today. In her presidential address, Dr MacKay said doctors are subsidising patients' healthcare out of their own pockets as general practice funding was, and I quote, a dog's breakfast. Dr MacKay also said DHBs were grossly underfunded, and that's what the DHBs have been telling us over the past fortnight. And we began with the program tonight. Dr MacKay, so we began the program with that tonight. Dr MacKay was outraged at the Health Minister's attacks on DHB, and particular Southern DHB, and called on him to, quote, sweep out the senior ranks of the manifestly incompetent ministry. Dr Pippa MacKay joins us on the phone now. Are you there, Dr MacKay?
I am.
Nice to talk to you. This was a fairly pointed and singular address from you. What was it in response to? Had it been bottling up for a while, or have events of the past couple of weeks really stirred you?
Yes, I think so, and I think that for general practitioners in daily practice, they stir us. But I was, as president of the NZMA, this is of course not NZMA policy. This is me being president, looking back over my past since I was chairman 15 odd years ago, and just looking at how things were. I dug out a few of my old medico-political editorials and looked at them and saw actually how relevant they were, and how many things had not changed or had in fact deteriorated.
Okay, what's deteriorated, do you think?
I think what you've been talking about in terms of access to elective services has certainly deteriorated. I mean, it hasn't been good for a long time, but it's far worse now than it ever was.
And there is a sense also, and boy, we're getting a lot of feedback from DHBs, and from some DHBs it's coming from staff in very senior positions, of quite an adversarial relationship between the DHBs and the ministry. Is that your sense?
Well, I come from Canterbury, so of course it's my sense. I mean, you know, the spats between the CDHB and Wellington are well known, certainly well known to me as someone who follows that. And I think that a lot of the doctors in Canterbury, I mean, we support our DHB strongly and admire our CEO, and a lot of the community in Canterbury is pretty outraged by the kind of targeting and selecting out of Canterbury DHB for criticism from Wellington, completely unjustified, we believe.
Yeah, and certainly the Canterbury DHB, if they would talk to us, I'm sure would say the same thing. Can we talk? We spoke to the Minister tonight. Our sense is that the collective deficit, there's about 16 DHBs are considered to have unfavourable forecasts out of 20. We think the collective deficit is about $100 million and growing fast. Do you think the financial pressure the DHBs is under is increasing?
Well, it certainly seems so. I mean, that's the sense that we get, and I know that. It seems that the money's getting stretched ever thinner. We know that there are lots of reasons why that might be, but there's just not enough money in the system. And no matter how you cut your cloth, you just can't do what's required of you when there's just not enough money going in. And I don't care what the health minister says about how much more money he's putting in each year. They're not putting in enough.
How do GPs respond to this then?
Well, I mean, practically speaking, as a GP, I tell people that their options very often for elective things are to pay or to stay in pain. Because, I mean, I can refer somebody, and we all refer people that we know will be turned down, and I mean, that's how it is. I mean, I frankly slightly resent having to repeatedly refer the same person to hospital. It's not as, it takes my time, and for my patients, I need to do what I can and try and get them seen. But what do you do? I mean, one of the other speakers this afternoon, Dr. Buzz Burrell, gave a very eloquent presentation on some of exactly these things, how people get bounced back to you. Somebody, a surgeon, for example, says somebody needs surgery, and they put them on the list, and a manager bumps them off and sends them back. That's crazy.
That process has been described to us on Checkpoint a couple of times, but if they don't bump them off and send them back and they go on the waiting list and the operation isn't done within 4 months, there's financial penalties, right? So the DHB are desperate to avoid having people wait too long, so the best thing to do is not put them on the list at all. And
how crazy is that? I mean, what is the health system there for? It's there to provide health services, for goodness sake.
So who's missing out?
Lots of people are missing out. I mean, what grieves me particularly is elderly people who have paid taxes all their lives, back in the day at 60% sometimes, and have had an expectation that their taxes would pay for their health care into the future and into their old age, and it's not. So there is that. I mean, we're talking, talking very much about elective surgery. Of course, in my practice, people who miss out are people who don't have any money. We're not a very low-cost access practice. I work in an affluent part of Christchurch, but I have a lot of people who are not affluent, and they aren't able to access the kind of funding that is available for some people around. So, lots of people are missing out on lots of things.
And so what happens if you're missing out? So if you don't have money or insurance or whatever, and you have to go through the public system, full stop, and you can't get into the public system, what sort of pain, what sort of conditions are you seeing people live with?
I guess particularly very painful joints where they are, their mobility is affected. They can't work, they can barely walk. They put on weight because they can't get any exercise, so that makes their arthritis worse. So a lot of that kind of thing.
A lot of that kind of thing?
A lot of that kind of thing. But as well as that, hernias, varicose veins, tubal ligations, gallbladder surgery, lots of things that are elective or semi-elective. I mean, what's the definition of elective, really? For some people, they're barely elective, they're necessary, they're absolutely essential.
The Minister, if he was listening to this, and I suspect one way or another he'll hear about it, would say, look, I've increased vote health significantly this year, it's at its highest ever level, and there is only so much money the taxpayer can afford. We need to get greater efficiencies from the system.
Well, of course he'd say that. But, there's been, in the last year, there were 97,000 extra New Zealanders just in the last year. I mean, there's been change. People live longer. We can do more. People's expectations are higher, and we've got far more people. So, they've got to put a lot of money in, but they've got to put more money in. And I think that we're just about getting as efficient as we can be. And the efficiency now is becoming punitively unreasonable.
Now, boy, people are using that word punitive a lot. I don't know how many people have said that to me over the past couple of weeks. Someone said it to me today, that the ministry feels punitive in terms of enforcing targets. That, of course, is the ministry's job, isn't it?
Well, the ministry's job is, if that's what they choose, if that's how they choose to do it, yes. I mean, the ministry is there to, I guess, provide the framework and the policy for providing health care and see that it's done. So, yes, I guess so. I mean, as I've said also in that address, I don't think they're doing it very well at all on lots of levels. But, there's got to be another way without financial penalties for waiting lists. There's got to be a better way than we've got. Now, the waiting list is an artificial thing. You can introduce a waiting list at any kind of artificial level, depending on how many points people have got to have, with any given condition. Say cataracts, for example, the points are much higher now than they used to be. So you've got to be much blinder than you used to be to get a cataract done. And it's an artificial thing used as a form of rationing. And, I think that doctors, and I'm sure most of the community, recognise that rationing is necessary, but it's all about how you do it and the size of the cake, I guess, that you're going to ration up.
Dr. Pippa MacKay, New Zealand Medical Association President, who spoke on the subject in Christchurch this afternoon. Thank you for joining us.